All right, we'll get going. And so today I'm tasked to talk to you about SPECT and PET-CT, and mainly for the evaluation of ischemic heart disease. So in the beginning of the year, we mentioned that we have multiple applications for nuclear cardiology. Today we're going to zoom on the one that's used most commonly, and many of you, when you get out to practice from fellowship, you're going to be required, at least by multiple employers, to have this skill. So it's important to learn this modality. Has been in the past decades is the most commonly used modality for assessment of coronary disease. Now we're seeing some shifts with the introduction of PET and CT. So we'll start with SPECT, and then we'll move on to the PET myocardial perfusion imaging. So I'm not going to cover in this talk stress modalities, because this was nicely covered earlier in the year by Dr. Nabi in his lecture about all the different stress agents, how we stress the patients, whether we use exercise, whether we use what happened here? Okay. Whether we use exercise or we use pharmacologic stress with dobutamine, or vasodilator stress with adenosine or regadenoson. So let's start with the SPECT protocols. If I can move my slides. Okay, so there are two main categories that we have in SPECT protocols. We have the one-day protocol and two-day protocol. Each place decided on these. If you are gonna go join an established lab, you'll see variety, at least in what's happening in the community. But I can tell you the most common, probably 90% of the sites, what they do is that they do a single day protocol, rest stress. So when we looked at Medicare data, that's the most common protocol that people use. And they start with the rest dose, and in that one you inject 8 to 12 millicurie. So your images are a little bit suboptimal because of the lower image quality. And then you stress the patient and inject 3 times that dose to shine it through. So you inject 3 times the dose, and you will get the information on the same day. So you have rest injection, stress injection. This is, I can tell you, like if you survey labs, this is the most common protocol that is used in the practice. There is another way to do it, which is the stress first. So you start with the stress. So then beauty of this protocol is that when you inject your stress injection, now you don't have any residual activity to start with. So there is nothing that you're shining through, or so because the patient doesn't have any radioactive radio tracer that's injected before. So you start with the stress, and then if you need, you can do the rest. The stress is going to be the lower dose, so the images are a little grainier, and then the rest will be the higher dose. It's always the second one is going to be the higher dose. The limitation of this protocol is that your images, the first set of images, are the lower dose kind of images. This may not be a problem in a non-obese patient, but it could be a problem in an obese patient. However, the nice thing about this protocol, and we adopt this one here, is that what we do is that if your stress images are normal, especially in a non-obese patient or not morbidly obese patient, then you can stop there and no need to expose the patient to another 3 times the dose. So that cut down a lot your radiation exposure. From a perspective of radiation, it is much lower. And there are some sites who are doing it with advanced cameras. They reported on their dose with 1 millisievert. So you're talking about SPECT with 1 millisievert, because you're lowering your image acquisition, you're lowering your dose, and you're doing stress only in these patients. Now, if you know that the patient is obese, and you're going to require anyway large doses to be able to get good image quality, I think you can start with 2-day protocol. Now, in a 2-day protocol, it doesn't really matter much whether you start with rest or stress. I personally, again, we in our lab have adopted a stress-first approach always. Why is that? Whether it's a single day or 2-day protocol. And the reason for that, because if your stress images are normal, then you can stop and you don't need to move with higher doses. So it's technically 1 day versus 2-day protocol and stress first or rest first. Obviously, if you do stress first, you'll always have the option of canceling the rest dose and lowering the radiation dose significantly for these patients. But the approach to this is that if you're going to do that, someone has to look at the images. Someone with experience have to look at the images and ensure that the quality of the images are very good and the patient is really doesn't need the rest images. So many of our fellows are in their second year or third year. When you're in the nuclear lab, you'll find that the tech calling you to look at this, do I need rest images? So if the images are good, normal, then you can go ahead. So one of our research fellows who's sitting there, she published a paper looking at if you do prone imaging or you do CT attenuation correction imaging, on the stress images, you reduce the need of rest imaging by 72%. So that's why most of the time that we want to encourage our patients to have the prone imaging and rest and the CT attenuation correction imaging, because with this we can negate the need for rest imaging in about 2/3 of the cases, and only 1/3 of the cases would potentially go to have rest imaging. And Dr. Mamarian and Cheng many years ago have shown that if you have normal perfusion and the patient underwent stress only or stress rest, the outcome is the same. So normal perfusion, and this is what we noted also in the recent paper by our fellow here, Maria. So you can see that if you look whether it is by not doing the rest, you're depriving the patient of important information that will determine their outcome. That's not the case. By having stress first in a normal study or stress only on a normal study, or having stress rest, really the outcome was not different after adjusting for all this information. So I think it is very important for us to review these images and make sure whether the patient needs their stress. Sometimes proning could help, sometimes adding CT attenuation could help, but if it is needed, we have to do it because our goal, our primary goal is to provide adequate imaging, reproducible imaging for these patients. All right, so I'm gonna show you some cases now and hopefully we'll try to answer some of these questions here. So looking at this patient, I'll give you the first one. So obviously when we look at this, we look at 17 segments when we try to interpret them. The regular or the standard projection of these images, that's stress on top, rest on the lower end, and then you try to look whether there is homogeneous uptake of the radio tracer and stress and rest imaging. In this case, let's see if I can move the mouse there. Okay, so in this case, you see that the anterolateral wall has less uptake compared to the rest imaging and compared to the other segments that you see on stress imaging, which actually confirm that this is an abnormal study. Now, again, you have to look at the quality of the images and how we identify these. So let's look at this case. This is a 59-year-old male with chest pain. Anyone want to shout out what do you see here? So the inferior wall there is a perfusion defect, and is it on stress, rest, and on, so it's on both. So when you have this, the differential is 1 out of 3 things. It could be scar, could be an attenuation artifact, or in less cases, yesterday we saw one in the PET lab, it can be resting ischemia. So hibernating myocardium, resting ischemia could potentially give you that. So one easy way to look at it is to do either prone imaging or to do attenuation correction. So here's an attenuation correction image of the same patient. So what do we see here? Is it still there or? So clearly if you've seen this patient at the stress stage and you've done CT attenuation correction, and this was a stress first protocol, then you would have stopped there because it's a normal study and there is no need to move further. So by using attenuation correction, we can correct many of these artifacts, and the main challenge that fellows actually see when you are reading with SPECT is to identify what's a true defect and what's an attenuation artifact. So this problem does not usually exist in PET, but there are other issues that we have to master with PET. But with SPECT, the main thing is to know what is real and what's not real. And as a patient gets more obese, you can see that, I don't know what's happening here, but as a patient, as we see more obese patient, then there is more chance that this becomes more not real. And here's another example of another inferior defect that improves with attenuation correction. So attenuation correction reduces artifact and enhances specificity. So that's actually a general board, general cardiology even board question, as well as nuclear cardiology board. So there have been multiple studies, and this is a meta-analysis we did for the hybrid imaging guidelines that I had the honor of chairing. And when we look at these, sensitivity, I don't know what's happening. Okay, so sensitivity should not, at least based on the cumulative evidence, is not changing when you do attenuation correction. So a true defect should still be present on both. But your specificity improves because you see less artifacts in these cases. And in another 20-year-old study by the Mid-America Heart Institute group, they actually shown that it's actually more important in obese patients. So if the patient BMI is 30, you can see the specificity was really low, and you can see that the improvement when the screen comes back, that the improvement in specificity is significant by using attenuation correction. Now some people ask what do we need to do attenuation correction? You need an extremely low dose CT. So that's why the CT that's usually attached to the nuclear cameras are, at least the SPECT ones are, like our machine is only a 2-slice CT, and you can do it with a radiation dose that's equivalent to 4 chest X-rays PA lateral. So it's equivalent to a radiation dose of a trip to Europe and back. So that's what you get the CT for attenuation correction, but that could potentially, as we said, save the patient having an additional scan either on the same day or on another day. So it's a very low dose radiation dose. It's free breathing, so we don't ask the patient to hold their breath. It's not gated, and we reconstructed at 2.5 millimeter. It's still very important to look at these and try to identify some abnormalities. Obviously, they're not diagnostic, but if there is a 5 centimeter mass in the lung, you will still be able to see it. And it's very important for all of you as SPECT-CT becomes more available to gain that expertise to be able to interpret these incidental findings on these low-dose CT. They're usually going to be major findings. We're not talking about a small granuloma here and there. We're talking about a 5 centimeter lung, mass, or we're talking about a large pericardial effusion or pneumothorax, things that we often see here and there. Now, even with artificial intelligence, there are few products that are available in the market that can potentially even do attenuation correction without the need for CT. This is one product that's available on one machine that's in the market, where you can see here that on the top, let's see if so here it's not corrected, so this is how they acquired, and there is a perfusion defect there. When they went ahead and did CT attenuation correction, this is how the images look. It fixed that inferior defect. And when they used the AI-based algorithm, it also fixed that. So these are tools that are available in the market, and many sites actually use this one on one of the specific cameras that we don't have here. And this potentially could give you attenuation correction without CT. There are two other solutions that are in the making by the software companies. This is also another one here where you can see attenuation correction, and that defect goes away whether by attenuation correction by CT, and this is by the artificial intelligence tool. And it provided similar diagnostic accuracy to using CT. This is another one from another software where there is, for example, an anterior defect, went away with attenuation correction, and went away with artificial intelligence. All right, so we're done with attenuation correction. Let's talk about something else. So who want to interpret this scan? This is a 73-year-old patient who came in to me a few years ago with chest pain. He walked on the treadmill for about just 3 minutes, and he couldn't walk more. And these are the images. Anyone sees any perfusion defect?
I don't see any perfusion defect.
You don't see any perfusion defect. Okay. I mean, some people might say there's a small inferior fixed defect. That's also seen, but it's a fixed, not ischemic version. Now, in our protocol, we, as you know, if the patient doesn't have known CAD, we get a calcium score, and this is his calcium score. His calcium score number was 1700. So, what should you say?
Recommend further evaluation with PAD.
No, what should you, I mean, clearly, first of all, the patient only exercised for 3 minutes. Although he touched his target heart rate, that's not a good exercise by any means, duration. And now you have a very high calcium score. So clearly, if you believe his symptoms, we sent him to the cath lab, and he has multivessel disease. And he was clearly ischemic, but he was not going further because he was having a lot of symptoms. So if you know in the guidelines, in the American and the European guidelines, in the American guidelines, it has a class 2A indication that for intermediate to high risk patients undergoing SPECT or PET imaging, adding calcium score is recommended. And the Europeans actually gave it class 1 indication. This is based on a lot of mostly cohort studies. It makes sense. Obviously, there is no randomized data whether you got calcium versus no calcium, but there are at least about 8 to 10 cohort studies that I'm aware of between SPECT and PET imaging that shows that by adding calcium score, you enhance the accuracy. But the landmark study also comes from here, from Dr. Nabi and Dr. Cheng. This is 16 years ago, when they were much younger, and they showed that by adding calcium score, whether it is to normal perfusion or abnormal perfusion, see if I can get the mouse. So whether it's the dark color or the lighter color, you can see they added incremental prognostic value over not including calcium score in these cases. So, and this is for all cardiac events and also for all-cause mortality. So I think at least for many years I've been running around and saying that nuclear cardiology should not be any more ischemia, no ischemia. We should move from this paradigm to a more broader kind of algorithm where we call no atherosclerosis, no ischemia, and this is what we have been doing here. Or atherosclerosis but no ischemia, which is probably the bulk of your patients. And then finally atherosclerosis with ischemia. I think this is a very important notion, and you can look at atherosclerosis by just looking at the CT for attenuation correction. You can see if there is calcium. Obviously, you might miss some mild calcification, but here we also add a dedicated calcium score as part of the test. So I think this is very important to kind of look at you as you go into practice, to look into these and incorporate the atherosclerosis information in addition to the functional imaging, because that has implications for therapeutics and also for the outcomes of these patients, and sometimes the diagnostic accuracy of the test. So if you see a normal perfusion but the calcium score is very high and the patient has good story, then you're gonna go ahead and look for these. So let's do more cases. 75-year-old, shortness of breath, atrial fibrillation. All right, what do you think? This was a stress-only study. Any defect? Nothing?
I mean, there's nothing I can see.
Yeah, nothing there. But the calcium score was 1253. So they decided to go ahead with the CT after that. The CT showed left main as well as ostial proximal RCA. Patient went for FFR CT and the LAD and circ were significant. The RCA was not called significant, and it was confirmed by coronary angiography to be severe left main. So I think that because of cases like this, you find that statement in our nuclear report. We have a good bunch of them that they have normal perfusion by but very high calcium score. A common question that fellows and others ask, if I see high calcium score and the stress perfusion is normal, shall I do rest? And my always answer is, what is rest going to add? It will add one thing, which is TID. So it will give you transient ischemic, if the cavity dilated, transient ischemic dilatation. So it's not gonna add much for you, and that's why I don't feel that by adding this, rather go to another study, whether it's cath or PET, would potentially add more incremental value for your patient there. Let's do another case. 64-year-old man, hypertension, dyslipidemia, coming in with chest pain. So these are the raw images, which I have not shown you before in this lecture, but part of the interpretation, we have to look at these to look at the homogeneity, motion, and accuracy. Here you don't see motion. You kind of do your quality control of interpretation on this screen. And you see homogeneous uptake, at least in the heart, but also in the gut here. But the most important is that there is no motion. And you can see some soft tissue attenuation. So these are the images here. So on top you have the supine, prone, and then you have a rest image.
I mean, maybe there's like a min-fix, small min-fix inferior defect, but I don't see any clear ischemic defect. And then also in the basal segments, the same thing.
Yeah, so the point, the reason I brought this up, because for you, again, if I manage to get the mouse there.
And the inferior defect,
So there is an inferior defect, and this inferior defect clearly in part attenuation and in part is probably a true defect, because when you look at the defect, now it gets, let's see, where is this mouse? This is very confusing. So there is remnant defect that you see in the basal inferior even after you prone the patient. So it does improve, but does not completely improve, which makes me usually somewhat concerned if I'm looking at a prone imaging, because prone imaging is not a perfect attenuation correction. So there was also some regional wall motion abnormality in there, in that area, and this patient actually did go for angiography. There was not much in the left system, but the RCA was totally occluded there, so there was an RCA CTO, which could be an infarct there related to this. So again, the defect that does not completely improve, you have to be very careful with these. So prone imaging is good, but it's not as good as attenuation correction. So if you have attenuation correction, it is a better tool to do for these patients. So at the end of this SPECT part, before we move on to PET, I think if you're gonna go to practice and practice SPECT in this era, I mean, obviously PET is a better modality, but still access to PET is an issue, and SPECT is the most commonly used modality. So if you're gonna use SPECT and you want it to be the modern kind of class, then use attenuation correction for obvious reasons. Always assess atherosclerosis either by a calcium score or by looking at the CT. And then finally do some of the newer protocols like stress only. So doing stress first and stopping after this will help reduce the radiation exposure. So, and again, now the target is that from ASNC and other societies is that we want our median radiation exposure to be less than 5, and we can achieve it if we do stress first approaches, because that will lower significantly your radiation dose. Remember, when you add a second scan, you're not just adding the same amount of radiation, you're adding 3 times more the exposure, because your dose is gonna be 3 times. All right, so even with using all of these tools that we have, sometimes we still struggle with artifacts and others, and that's why you need other modalities. And here we're gonna talk about PET. With PET, you have high diagnostic accuracy. The data, when it was compared head-to-head with other imaging modalities, specifically with SPECT, but also with CT and other, shows that the highest imaging diagnostic accuracy is with PET. There's consistent high-quality images, and I'll show you that. There is low radiation exposure, even though the patient is getting a higher energy radiotracer, but because of the half-life is very short, so they still end up with 1 to 2 millisievert radiation dose, especially with rubidium, compared to the other imaging modalities. We also have short acquisition protocols. So compared to SPECT protocols, which are a little longer, with PET from start to end, and I'll show you the protocols we use, they are about 20 minutes on the table or so. And then I think the best value proposition for cardiac PET is the quantification of myocardial blood flow, and this is where it adds a lot of information and you try to integrate it with the information. Now, one thing to remember also about cardiac PET is that you combine it with CT, the combination with CT, attenuation correction in PET is not an option. It's mandatory. So you always, and nowadays, we have almost the main method on the current new scanners is by CT. So there are PET MRs that use MRI for attenuation correction. There are some old source cameras that could use that. But if you're gonna go to the market and try to buy a PET CT now, you're gonna only find PET CTs. And so with that means that you can do CT for almost all your patients and get information about atherosclerosis. Again, we do not look at non-attenuation correction images due to some physics principles I talked about in the earlier lecture back in July. So what are the tracers that are available? In our lab here, we use the one to the far left or to the far right. So we use rubidium or flurpiridaz. In the US, ammonia is also approved, but O15 water is not approved in the US. It's currently in randomized clinical trials, and it is being evaluated. The main advantage of rubidium is that it is generator based. So technically, you buy a generator every 40 days, and so you have that generator available for you to be able to evaluate these patients. There are two available commercial solutions that you can buy, one or the other, and they are pictured on this slide, but they're also all available. Like once you get it, you can use it constantly for 42 days. It has a very short half-life, 75 seconds. So technically, this one has to be put next to the machine and inject from the injector to the patient. And the one that you get is not the injector. You get this one. You get this generator, this one or this one. You get it every 42 days. How much you inject depends on your camera. So if you have a high-end camera, you can inject lower doses. If you have a lower-end camera, then you have to inject higher doses. And we injected over 30 seconds. There is no manual injection, so it's all by the machine. You go in there. It's like an iPad. You put how much you want to give the patient. I press inject, and it's all automated. The techs come 1 hour earlier every morning to do QC to the machine, make sure that it's working fine, and then they can do it. If you do a lot of cases, like 13, 14 cases or above, then you run into the issue that you have to repeat QC in the middle of the day. So some practices who do a lot of cases start at 6, go till 10 p.m., then at around 4 p.m. or so, they have to repeat the QC as mandated by the FDA. The protocol is, as you see here, it's a 25-minute on the table or so. You can squeeze it in about 20 minutes. It depends how efficient your team is. But this is the table time. Obviously, the patient needs a little bit before, a little bit after. So we inject, we get a scout, we do a CT attenuation correction, then we get a rest first. So with PET, we try always to get rest first, because the rest here is going to be a true rest. Once we give our stress agent, we don't want to wait until the patient rests again. So we always do rest first. And in contrary to what we do with SPECT, we always do rest and stress. There have been some suggestions to do stress only PET, but because the radiation dose is so small and there is so much information we get by doing the rest imaging, including the rest myocardial blood flow, then we have elected to do both. So the protocol, we inject for 7 minutes. The 2 injections have to be separate by 10 minutes as per the generator characteristics. Then we go ahead and inject regadenoson or other stress agent, and then we acquire another imaging and finish up with a quick CT. So the protocol is very quick. Patient is on the table one time, and that's it. This is the image of one of the big size patients that we have. So you can appreciate the quality of the images compared to the SPECT images that you've seen before. This is a BMI of 76. So this is not, again, the biggest. We still have a couple bigger, higher BMIs. Our table limit is, I think, 550, but this was a short patient, so that's why the BMI is pretty high. And you can see here with the with like all the subcutaneous fat that's there. So the image quality, if you do it right and you do your injection right, then you are able to get consistently high quality images at irrespective of the BMI and irrespective of the generator. So moving on to the other tracer that we are using in our lab is flurpiridaz. It was approved in end of 2024. We were the first site to use it, and so far we've done about 250 cases or so. And I'll show you some cases today from these. The advantage of this one is that it is F18 base, so it has a better image quality. Even that the image quality with rubidium is good, this one is even better image quality. So it has several advantages. One of them, and as you see here, Dr. Alwan, our postdoc, puts this nice infographic that you'll find on the ACC website. So you can see that it has multiple advantages compared to rubidium. So it actually binds to the mitochondria. It has high myocardial affinity. So the uptake by the myocardium is almost 94% compared to lower uptake by rubidium. Although I have to say rubidium also has correction factors, so but still to have a true higher affinity uptake is better than having something that you correct for. Also, the image quality is very good. It has better spatial resolution, and one of the main advantages is that because the half-life is longer, then you can do exercise studies. So technically, with rubidium, we cannot do exercise because the patient is on the treadmill, and we usually want the camera to be on when we are injecting them. So with rubidium, if you inject them while on the treadmill, by the time you put them on the table, the dose have decayed and you're not going to be able to get the information. But here, you can do the treadmill, let them rest, their breathing slows down, and then you can bring them back and do the imaging. So we can discuss whether it's important to do exercise or to do pharmacologic and get the data. This is the image quality that you see here. And the image quality compared in the pivotal trial to SPECT, so this is the same patient. You see the SPECT images on top, you see the PET images on the bottom, and you can see that this patient at least looked normal on SPECT, but looked very abnormal on PET. And this is actually not from our lab, this is from the trial. It was published back in from the phase 2 trial, and some of these images kind of make you wonder what happened, why we missed it on SPECT imaging. So the exercise protocol, we're not doing it on everyone. It's a little bit of a longer protocol because the current exercise protocol does not allow you to measure blood flow. There are right now some modifications to it happening, and people, I'm assuming hopefully in 2 to 3 years we will see a protocol that will allow us to do blood flow, but we are currently reserving it to patients who cannot get pharmacologic stress, patients with anomalous coronaries, or patients with myocardial bridging. So these are the patients that we are doing this on right now. With pharmacologic stress, the protocol is a little bit longer. This is a protocol that's approved by the FDA, and it calls for a 30-minute delay between the rest and stress injection. And this is what's on the package insert for the fellows. If you look at the package insert when it comes, this is how it looks. In our group, we thought that we can make a modification to that, and the paper is coming out soon. And now it's in press, where we come up with our own protocol here, where we modified the initial FDA protocol to make it, instead of a 45-minute protocol, a 22-minute protocol. And this is what we use here. So we reduce the rest dose so we can achieve a higher. So our rest dose went down from 3 to 2, and then this way we are able to shine it through when we give 3 times the dose with stress. So that's what we are doing here, back to back, and in the upcoming paper we will show that by doing so we are in this ratio here of 3, because we're going to be 6 to 2. So our residual dose is going to be much lower, less than the desired 20%. So we felt that this is a better way of doing this. Anyway, I'm reducing the dose, so that's good for the patient. And I'm also not blocking the table for a long time. So this is the protocol we are using here. So the question is, in general, for PET in general, not flurpiridaz or rubidium, how do we select our patients? Obviously, if you can do PET for everybody, that would be your test. Patients, actually, there are some institutions actually whose question is the other way. They will come to you and say, why, if you want to order a SPECT, you have to justify it to your administrator. So for PET, for them it is faster, especially for inpatient. You don't block a bed for an inpatient, especially the current hospital being busy and others and the beds. But at the same time, cost is much higher for PET compared to SPECT. And that's why we are like limited by the reality. But I can tell you, by our practice here and our patient population and our third-party payers, if there is a prior suboptimal, so for the fellows, if you're in SPECT and you know that the prior images were done and they looked more guessing than true interpretation, then don't waste your time and order another SPECT, because it's going to be another time guessing, unless you tell me the patient lost 100 pounds or so. But if there is, so if the reason is weight, breast implants, emphysematous lung disease, don't waste your time to get another suboptimal SPECT. Either go for another imaging modality, or if nuclear is the appropriate modality for this patient, then go ahead with PET for these patients. Obviously, once the BMI becomes high, all imaging modalities start to suffer, but we've shown you that many of these patients have better image quality with PET, and most insurances would approve BMI above 35, but there is one carrier that will insist on it to be 40 or so. And then if there is a high calcium score, because the risk of balance ischemia in these cases, so we try to preferentially, if you know that their calcium score is 1,000 or so. Dr. Rifai here published a paper about 1,000 patients who have 1,000 calcium score plus, and clearly shows that these patients do better in terms of outcomes if we show normal perfusion and normal blood flow in these cases. Prior cardiac transplant, there is no role for SPECT because we look at blood flow. If you're trying to diagnose microvascular dysfunction, this is how we do it with PET rather than SPECT. And microvascular dysfunction, I want to highlight that obviously most of the time we look at the epicardial vessels, but there's a whole network of vessels that we do not see very well, and we should learn more about these by looking at the blood flow measurement at the tissue level. So how we do that, there is some mathematical modeling that's happening, whether it depends whether you have flurpiridaz or rubidium. It has some corrections for uptake and retention, and then the model, it's not an additional acquisition, so there is no extra radiation exposure for the patient. It is actually more of a mod of reconstruction of the images that we acquired, and then we can calculate the blood flow. It takes about 30 seconds on the software once the images are ready. And in this paper, they've shown that in patients who have normal myocardial blood flow reserve, the chance of missing obstructive disease across the board in a high-risk population is less than 3%. So it is very high accuracy. And then in the chest pain guidelines, in the American chest pain guidelines, they clearly shown that if the patient has already had an anatomical study, there is no obstructive disease, but they continue to have chest pain, then you can look at myocardial blood flow to assess for microvascular dysfunction. In this study, they gave it class 2A, and they said it's either stress PET or stress CMR only if blood flow quantification is done. And then you can look if there is reduced myocardial blood flow, then you can diagnose microvascular dysfunction. In addition, plus or minus ischemia if these patients have that. So recently, we've published also some data from our group looking at the rest of blood flow. So the rest blood flow is actually your best predictor of recurrent heart failure admission. There are multiple papers on this, multiple papers from our group on this, and there are soon from other groups, but you can clearly see. So having a high resting blood flow is not a good sign for the patient. The patient means that they need more blood flow to maintain their cardiac muscle demand. All right, so I'm gonna quickly skip through this. I'll give you the QR code and I will do some cases. So we're not done yet, but I thought I'll put it for you. This is for attendance for the fellows, Dr. Arif. All right, everyone is done or not yet? Done? All right, the chiefs give me the sign to move on. All right, so when we are looking at the blood flow, so when we are interpreting a PET study, this is a slide I put here where we look at what I call a PET toolkit. So you have so many integrated information. I didn't put the EKG here, but the EKG is also another aspect there. So you have the relative perfusion where you look at the defect size, location, severity, reversibility, RV uptake, all of that, TID. You have also the rest EF, stress EF, and the delta and the ejection fraction. You have the perfusion defect where you can get a lot of other measures, rest blood flow, stress flow, MFR, corrected MFR, regional MFR, all of these. And then you have the calcium score. And we're adding even more information from the CT, like the fat and other information. Now, the first question that comes to us is that how do these numbers compare between the two tracers we use here? So this is another case report by our postdoc where in the same patient underwent a clinically indicated rubidium study and then a research flurpiridaz PET. So you can see here in the same patient, you can see the image quality, and that's partly because of rubidium versus F18. You can see the blood flow with rubidium was a little higher, but the stress blood flow with flurpiridaz was higher, which means that we can see higher flow reserve with flurpiridaz. And there is something that Dr. Saad, who was sitting in the back, described first here. It's called splenic switch off. And you can see here that the splenic switch off means that you can assess the adequacy of the stress. And you can see that the spleen has some uptake here, if I can manage to get the mouse. Anyway, you can see it there. The spleen has some uptake, which gets worse with, which gets less with the stress. So when you give regadenoson, the spleen has less blood flow. There is splanchnic vasoconstriction, so you get less gut uptake because hopefully the blood is being directed to the heart. All right, Dr. Ilyas, where's the microphone next to you? What do you see here? I know you haven't done PET, but this is easy.
Yes, so we have an anterior wall and apical defect that goes away with rest.
So clearly a large anterior defect, which is actually,
larger.
so the question is, where is it, from where? So the proximal segment of the anterior wall is not affected, but then you see the
Mid-LAD, I would
anterior,
say.
and then, so it's a defect in the LAD. Now, at this time, we're already convinced that there is a LAD disease, so you probably tell me, like, why do I need the additional information? Partly because we want to know if it's a single vessel or multi-vessel disease. This could still be multi-vessel disease, but the worst lesion is in the LAD. So we haven't known that yet. So when we move on, now look at the calcium. So we see calcium in the LAD, and in the other vessels it was less. And what about the flow now?
Looks like the
Last
flows are
summer.
only low in the LAD territory and normal in the
Yes.
CERC and the RTA.
So it's much lower in the LAD compared to what we see in the other territories. You can see the flow reserve, it's better in the, let's see if I can get this. This is, probably should get it. Yeah, so you can see the flow reserve. The global is reduced, but that's partly because the defect is so large. And we can even go further and try to locate where that location is. So when you look, the first segment of the anterior wall, the basal anterior, has normal perfusion. I can show you here. Back, so you can see that the first segment is normal and the second segment is dropping. You can tell that the basal anterior, the segment of the LAD that's involving the basal segment is normal, but then it drops significantly in the mid. So it's actually more of a mid LAD lesion. You can see on the angiogram that there is a diagonal branch before. All right, so let's compare this to this case and then can potentially stop. So what do you think of this case? No tricks here.
Looks normal.
Looks
Both
normal, right?
stress and rest, yes.
But looking at the calcium, this is even worse calcium, 3,313.
Flow reserves.
Now let's look at the flows. What do we see here?
They're all normal.
So it's all normal. So despite having a calcium score of 3,000, your flow is normal. And the peak flow is also very normal. So now let's dig deeper and look at the regionality of it. We have a fellow who's presenting in the ACC also on this aspect specifically. So you can see that whether in the LAD where a lot of the calcium was, there's no regionality in there. So it tells you there is diffuse disease, but you're pretty confident that there is no obstructive disease in that lesion. So it's all this calcium, probably more in the media rather than in the vessel. So let's finish up with this case. This is a recent case from one of our colleagues, and we have a fellow who knows the history of this patient. So patient had multiple workup, 74-year-old man, and on an anatomic study, they found a deep myocardial bridge and a moderate LAD. So he was referred for an exercise PET. This is an exercise PET with flurpiridaz. So once we say exercise, we're going to talk flurpiridaz here. So what do you see?
Ischemia in the LAD territory.
Very large ischemia. Although the LAD was called moderate lesion, but also there is a myocardial bridge. So probably both of them are contributing to ischemia. And this patient had 2.5 millimeter ST depression with exercise. Notably, the patient had a prior rubidium PET read by a different person, but again, I looked at it and it was not showing ischemia. So it's kind of interesting that if you're trying to see ischemia from from myocardial bridges or from anomalous coronaries, you want something that kind of resembles increase in the heart rate and exercise workload. So again, it could have been that the lesion was not severe enough and now it's more severe, but you can note, but it could be also that the fact that we did not elicit ischemia because the first one was a vasodilator study and this one is an exercise study. Okay? Any questions? All right. Thank you.